Rahim. The topic of my discussion today, in light of the continuation of our previous lectures regarding uveitis, is Behcet's disease. So, by the end of this discussion, we all will be able to give a brief account of the signs and symptoms, clinical features, differential diagnosis, and management regarding Behcet's disease. So, this is what a patient of Behcet's disease should present in the OPD theoretically, since I have never encountered a patient of Behcet's disease in my minimal experience. So, a 20-year-old male presents with recurrent panuveitis that can be bilateral, associated with painful buccal and genital ulcers with subcut nodules and pustules on the trunk with positive pathogy test. Laboratory examinations are usually non-revealing except for a minimal rise in ESR. So coming to the background, Behcet's disease was first described by a Turkish dermatologist back in the 19th century when he encountered some patients with skin lesions and oral ulcers characteristic. So it is an idiopathic autoimmune multi-system disorder which is primarily characterized by aphthous ulcers, recurrent and painful, genital ulcers, and uveitis. The most important thing that has to be kept in mind regarding Behcet's is vasculitis, which is pathogenetic and involves both arteries and veins and all types of arteries such as small, medium and large arteries as well as veins. And the major cause of mortality that occurs in 5 to 10% of the patients is due to the cardiovascular system or the central nervous system complications that are linked to vasculitis. So, coming to the epidemiology of Behcet's, you can see that the red highlighted area is the Silk Road route extending from Far East to the Central Europe, and this is the main belt which affects the patients located in this area. So, maximum number of patients that have been encountered so far, this is a 2018 epidemiological data, shows that they were seen in Turkey, followed by uh, different regions. They were more in Iran, then from Japan, China, Korea, coming to the Europe. The areas of Southeast Asia, North America, South America were relatively spared. And you can see the usual onset is in the early 20s. It is rare before the puberty or after the age of 50, and the maximum number of patients are encountered in their 30s. So the rate is equal in men and women, but the disease is severe in men and compared to the women, and the mortality is also relatively higher in men compared to women. So maximum patients affected from Turkey, then the Middle and Far East, lower comparatively in Europe and America, males affected more, ocular disease being more severe in males compared to the females. So like in any other autoimmune disease process, the pathophysiology is unknown. There are, however, these two postulated theories that there is an aberrant immune activity triggered by an exposure to agent in patients with a genetic predisposition to HLA-B51, and some environmental factors that can trigger an abnormal immune response, such as viruses, such as herpes, hepatitis, bacterial agents, or pollutants. So coming to the systemic features of Behcet's disease, now international study group for Behcet's disease classification gave a diagnostic criteria for Behcet's. So recurrent oral ulceration for 3 or more times in the last 12 months, that should be associated with at least two of these four conditions: genital ulceration, ocular inflammation that can be a pan-uveitic appearance or just anterior uveitis, intermediate or posterior uveitis. Characteristic skin lesions such as erythema nodosum, pseudofolliculitis, papillopustular lesions, and then the pathogy reaction. We will discuss it further in the presentation. Additional features that are encountered are vascular lesions. They can be coronary aneurysms, pulmonary aneurysms, thrombophlebitis, arthritis can be an association, but mostly there is arthralgia seen in 30% of the patients. Then there is dermatographia, which is somewhat similar to pathogy reaction. It just shows a hypersensitive response to stroking the skin. There is a characteristic cutaneous reddish lesion. I'll show you the pictures. Neurological manifestations such as encephalitis, cerebral aneurysms, and then cerebral vasculitis, that is one of the major causes of death in these patients. Gastrointestinal lesions, mostly ileocecal inflammations are common, and then the hepatic and renal lesions. This is a diagram that shows the areas of vasculitis that are caused by Behcet's disease. You can see roughly every system is involved by this disease. Now, this is a picture of aphthous ulcers. You can see the buccal mucosa is involved. Mostly they are painful, they are recurrent. This is dermatographia. You can see the hypersensitive reddish lines that are seen on the both these pictures. These are pictures of forearms. You can see that there is a hypersensitive reaction resulting as a result of stroking and scratching. So now coming to the ocular features. So 70% of the patients, so ocular features occur in 70% of the patients with Behcet's disease, and 10% of the patients with Behcet's disease present with ocular features. And it is the ocular features include acute onset panuveitis and vasculitis, which can be symmetrical, asymmetrical, usually bilateral, with a characteristic relapsing, remitting pattern of disease with spontaneous resolution without treatment. So, most of these cases that were reported had a previous history of spontaneous resolution without treatment. And the major cause of visual compromise was retinal vein occlusion and vasculitis in these patients. So acute anterior uveitis, transient mobile hypopyon is characteristic with a relatively white eye. That means that there are no other signs of acute anterior uveitis seen in these patients apart from a mobile hypopyon. Then there is vitritis, which can be severe, obscuring the view of the fundus. Then there is retinitis that is characterized by retinal infiltrates, which are seen as yellow whitish spots with ill-defined borders. They also resolve spontaneously on their own without any treatments, leaving a scar. And then there is the retinal vasculitis that involves both the arteries and the veins without any sparing. In some cases, there is optic disc hyperemia and edema. It can be as a result of inflammation secondary to posterior uveitis, vasculitis. It can also occur as a result of raised intracranial pressure in patients of Behcet's disease. Finally, as with all inflammatory ocular events, there is ischemia which leads to disc and retinal neovascularizations. Uncommon manifestations include conjunctivitis, episcleritis, scleritis. There can be ophthalmoplegia due to neurological involvement of the extraocular muscles. The end-stage disease is characterized by optic atrophy, retinal atrophy, gliosis, sheathing and ghosting of blood vessels, retinal detachment. Complications can include cataract, neovascular glaucoma, and then finally phthisis. So I'll show you the pictures of the ocular features that I just described. There is something wrong with this picture. Can anybody point it out? I realized this after I made the presentation. So there is hypopion, but there's something wrong with this picture. This is a picture of acute anterior uveitis, but in Behcet's the eye is relatively quiet, but there is mobile hypopion. So this is what's wrong with the picture. So this is severe vitritis. You can see that there is a faint appearance of the blood vessels, but the fundus in general is hazy. That is because of vitritis. Now coming to retinal vasculitis, on the left side you can see that there is the involvement of the supratemporal vascular arcades. There is massive sheathing with somewhat exudation and bleeding. There is a large area of intraretinal bleed, approximately 2 to 3 disc diameter in size, temporal to the fovea in the left side. On the right side, you can see that the overall color of the fundus has turned from this yellowish orange to gray. That is because of generalized ischemia as a result of vasculitis. You can see almost all of the vessels have whitish discoloration on the margins of blood vessels that shows sheathing. Then the vessels are occluded in further peripheries. You can see there is sclerosis of all the blood vessels that is seen in the peripheries associated with some intraretinal bleeds and hemorrhages. Here's another picture. In this one, you can see in the left picture, you can see that in the superior vascular arcade, there is a blood vessel that is characteristically sheathed. You can see that there is whitish discoloration on the margins of the blood vessels associated with leakages. Multiple hemorrhages are also seen. On the right side, you can see that there is vitritis because the view of the fundus is hazy, and there are patches of retinal infiltrate seen in the supratemporal quadrant. You see there are two spots of retinal infiltrates. In the infratemporal vascular arcade, you can see that the vessel is sclerosed, and the area and there is a vein occlusion, infratemporal branch retinal vein occlusion seen on the right side. So this is how the retinal infiltrates look like, these yellowish white spots. You can see they have ill-defined borders and they are yellow whitish in color. Similarly in this second photograph. When they are old and healed, they have well-defined borders and they settle without significant reaction. So optic disc edema, as we have discussed, it can occur due to both the reasons. The first reason can be raised intracranial pressure because of Behcet's, and the other reason can be due to inflammation if there is vasculitis. You can see that there is blurring of the optic disc margins. You cannot appreciate the vertical cup disc ratio. There is severe hyperemia of the blood vessels. They are dilated, tortuous. Similarly, in this picture, you can see there is a small splinter hemorrhage that is also visible with optic disc edema. So, as a result of ischemia secondary to inflammation, you can see that there is neovascularization on the disc. There is an arborizing pattern of blood vessels emanating from the disc coming towards the vitreous. They are present in this one too. They are more significant in this photograph, initial stages in this one, and then there is bleeding from these neo vessels seen in this diagram. You can see some dilated blood vessels in this picture too. So these are a few pictures of optic atrophy. You can see that the optic disc in all these three pictures have changed its appearance from pinkish orange to yellow white. There is sclerosis, advanced sclerosis of all the blood vessels emanating in this diagram. There is sheathing in this diagram along with optic atrophy, and then there is sheathing along with discoloration of the fundus in this photograph as a result of as a sequel of ischemia and inflammation. So coming to the differential diagnosis of Behcet's, we have seronegative spondyloarthropathy such as ankylosing spondylitis, Rhetus syndrome, inflammatory bowel disease such as Crohn's ulcerative and Whipple's disease. Then we have sarcoidosis, polyarthritis nodosa, Vogt-Koyanagi-Harada syndrome, Eales disease. Infectious causes include tuberculosis, syphilis, acute retinal necrosis, and Lyme's disease. So, investigations that can be done is first of all HLA-B51, which is the investigation of choice in these patients. Most of the patients who have an ethnic probability to develop Behcet's disease test positive for HLA-B51. Then there is the pathogy test. It is a very common test that is used that gives 95% specific results. A 23 gauge needle is obliquely inserted into the skin, and there is a pustular reaction that is seen 24 to 48 hours later. Then the white blood cell counts, ESR, CRP complement levels, they can be raised. Thrombophilia screening is done to rule out thrombosis in few susceptible male patients. Fundus fluorescein angiography can be done to rule out areas of ischemia, which can further lead to the treatment, the laser treatment for vasculitis. Then there is laser flare photometry, which gives a very specific quantitative analysis of the anterior chamber inflammation. It is done with the help of a laser beam that is targeted into the anterior chamber, and it measures the amount of proteins that are scattered in the anterior chamber into the aqueous humor as a result of breaking down of blood aqueous barrier. Then lesion biopsies can be taken from the synovial fluid, or lumbar puncture can be done to take some of the cerebrospinal fluid to assess, to check for the disease process. And then there is systemic imaging, which includes CT scan, MRI, and then venographies to rule out aneurysms and areas of vasculitis. So, coming to the treatment of Behcet's, the mainstay of treatment, as in all other uveitis, is immunosuppressives. So, if there is any no involvement of the posterior segment, topical steroids are the mainstay. We start with the hourly therapy and then tapering down depending upon the results. So, going down further, systemic steroids and azathioprine. So, according to European League Against Rheumatism in 2008, they give a suggestion to use a combination of. They did not give a suggestion. It was concluded that a combination of steroid and systemic steroids and azathioprine can be used against posterior segment disease. So steroids, as we know, is used in 1 milligram per kg per day, along with azathioprine 2.5 milligram per kg per day were used in combination. And if both of these had to be used for a prolonged period, azathioprine was decided to be a better drug for prophylaxis because of severe side effects of systemic steroids. So, in severe eye disease, that is two or more than two line of reduction in visual acuity, vasculitis, or the macular involvement, cyclosporin 2 to 5 milligram per kg per day or infliximab, along with azathioprine and systemic steroids, were postulated. In cases where there was significant side effects associated with azathioprine or systemic steroids, and single infusion of infliximab for initial treatment of posterior disease was also postulated. Now, a major concern was the toxicity of cyclosporin and infliximab. Cyclosporin is associated with neurotoxicity, hepatotoxicity, and hypertension. So these things have to be checked while giving this drug. And infliximab was associated with in reactivation of tuberculosis. So a prophylaxis of anti-tuberculosis therapy was also needed to counter the effects of infliximab. So keeping in mind these notorious side effects with these drugs, an intravitreal route for infliximab was also considered to be a good alternative. And infliximab or adalimumab should be considered early in sight-threatening disease. Uh, so right now for severe disease and severe posterior segment disease, we have discussed two major combinations, steroid and azathioprine and cyclosporin along with infliximab regime for severe disease. Now, they have very serious complications. So another alternative has also been postulated for the management, which is 6 million international units per day, initially subcutaneous, then tapered, with or without the use of steroids. Interferon alpha can be used as an alternative to the previously discussed two regimes. But one thing should be kept in mind that the interferon alpha should not be used with azathioprine because of the risk of myelosuppression. Thank you.
एक तो edema, the signs of ischemia, the pale of this, one sign. लेकिन रेटिना के ऊपर देखते हुए कौन कौन सी चीजें आप ले सकते हैं? So universal indirect evidence of ischemia. Is there any direct evidence? Like one doing that.
either from the other eye और उसकी जो तो उसकी बिॉप्सी रेट वहाँ रेफरेंस बेहतर है, उससे आप कंपेयर करेंगे तो आपको फेल होगा और आप खास तौर पे कोई ऐसा ब्रांच रेटिनल रीजन में देखा करें इसको। और दूसरा रेटिनल वेसल्स के अंदर क्या है, स्क्रीजिंग, स्क्लेरोसिस, वाइटनिंग। अगर किसी जगह पे एक पूरी फ्लूइड वेसल है तो बिल्कुल वाइट स्किन वाइट कोई होगी, रेटिनल इंडिकेशन पे वहाँ पे है। फॉर एग्जांपल आपको एक पेशेंट है और सबसे इंपॉर्टेंट एविडेंस क्या है, मतलब जो आप पेशेंट आया और आपने उसको एग्जामिन किया, फॉर एग्जांपल उसकी नेफ्रोडीमा आपको क्लिनिकली नहीं लग रहा, लेकिन उसकी विजन कॉमन फिंगर है मैकुला के ऊपर और आपको कोई चीज नहीं मिल रही, पेशेंट ब्रांच रेटिनल इंक्लूजन है, एडिमा भी इतना ज्यादा नहीं है या डायबिटिक पेशेंट है, तो आपने उसकी विजन देखी, तो विजन इज ए डायरेक्ट एविडेंस कि बाद आपको हर चीज नॉर्मल मिल रही है। अब आप उसका जब आप करेंगे, एंजियो स्कैन करेंगे या एंजियोग्राफी करेंगे, तो आपको पता चलेगा कि मैकुला का एफएजी लार्ज हुआ बिकॉज ऑफ डायबिटीज और बिकॉज ऑफ समथिंग एल्स, उसका जो एफएजी लार्ज हुआ। तो एफएजी इनलार्जमेंट की एक इनडायरेक्ट जो एविडेंस है, डायरेक्ट एविडेंस बल्कि वो विजन, ठीक है। और कोई साइन और साइन इट्स वेरी वेरी इंपॉर्टेंट। ये डायरेक्ट एविडेंस है कॉटन स्पॉट्स कि आप उस जगह पे इतना सा एरिया जो है वो वहां पे टोटल ब्लीडिंग होगी। ये 4-5 साइंस हैं आपके रेटिनल इस्कीमिया के, इसको आपको अंडरस्टैंड करना चाहिए कि जब भी आपने कोई ऐसी चीज खासतौर पर डायबिटिक रेटिनोपैथी देखनी है या वीनस फ्लोजन देखनी है या आपने वेस्कुलाइटिस के किसी पेशेंट को देखना है, तो आपने लाजमी तौर पर रेटिनल इस्कीमिया को आइडेंटिफाई करना है क्लिनिकली। कोई अब आके कुछ हुए हैं ये जो लार्ज एनालाइजर जो है बड़े 120-180 डिग्री के उसको एनालाइज करते हैं पेरिफेरल सर्कुलेशन को, वरना एंजियोग्राफी भी आपकी सिर्फ 30 डिग्री को देखती है एफएफए में। एंजियो स्कैन के बहुत सारे जो जितने अभी ओसीटीज आए हैं वो भी सेंट्रल एरिया को देखते हैं। आपको पेरिफेरी को आज भी अपनी नेकेड आई के साथ एग्जामिन करना पड़ता है कि आपने पेरिफेरी में इस्कीमिया का क्या हाल है, और हमने इस्कीमिया के ऊपर पेशेंट की प्रोग्नोसिस और उसकी सारी ट्रीटमेंट मैनेज करती है। अब डायबिटिक पेशेंट है, आपने उसके इस्कीमिया मिस कर दिया है तो आपने समझ लें बहुत मिस्टेक कर डाली है। अब अल्टीमेटली वो रुब्लोसिस या किसी और चीज लाएगा और आप उस वक्त तक आप पेशेंट को लूज कर सकते हो। तो ये 4-5 साइन आपको पता होना चाहिए कि ये 5 चीजें हैं, मैंने इनको देखना है कि इनमें से तो कोई चीज नहीं। और दूसरा वो जो अपनी साइक्लोस्पोरिन है ड्रग है, साइक्लोस्पोरिन के सबसे जो कॉमनेस्ट साइड इफेक्ट है दो, एक वो ब्लड प्रेशर करती है, सेकेंडली उसका जो नेफ्रोटॉक्सिन, तो उसका 3 मंथली इवैल्यूएशन ऑफ बीवी एंड क्रेडिट जो है वो करना चाहिए। हेपेटाटॉक्सिन यस इट इज, लेकिन इससे ज्यादा रिलेटिवली सेफ एज कम्पेयर टू एजाथेरेपिन, एज कम्पेयर टू स्टेरॉइड्स। साइक्लोस्पोरिन इज द वेरी सेफ अगर हम इसकी सारी ड्रग्स को देखें। तो साइक्लोस्पोरिन कैन बी गिवन, और मैं सुबह शॉप से देता हूँ अप्रोक्सीमेटली आपको 100 मिलीग्राम के बीपी दे दें एक मिडिल एज पेशेंट को, तो अर्ज नहीं होता। और उसके नेफ्रोटॉक्सिसिटी और ब्लड प्रेशर, तो ये दोनों साइड इफेक्ट्स बहुत कम है। न्यूरोटॉक्सिसिटी भी यस करते हैं रेट, नेफ्रोटॉक्सिसिटी
Okay. So, excellent presentation and good addition by Suhail Saab. So, the basic aim is to identify the disease so that we can start the treatment energetically. एक दफा जिस तरह होता है रेटिनल इस्कीमिया हो गया एंड देयर आर कॉम्प्लिकेशन लाइक मैकुलर एडिमा एंड ऑप्टिक डिस्क पैलर, so you can't do much. So the best thing is to prevent the damage, and that is to interfere at the earliest stage. OCT का क्या रोल हो सकता है? What can OCT detect? हाँ जी, इसका कोई रोल है? कराएंगे कि नहीं कराएंगे? पेशेंट आ गया, good. You see, VN is decreased. Now you are not sure whether it is because of macular edema or macular ischemia. So to rule out macular edema, you will have to do OCT. उसके बगैर कैसे रूल आउट करेंगे? और मैकुलर एडिमा होगा तो आप एंटी वेजेस देंगे, मैकुलर इस्कीमिया होगा तो नहीं देंगे। सो यू विल हैव टू हैव ओसीटी। और ओसीटी एंजियोग्राफी पे क्या फीचर्स आ सकती हैं? व्हाट आर द फाइंडिंग्स यू कैन डिटेक्ट ऑन ओसीटीए? न्यू वेसल्स, गुड, एंड enlarged foveal avascular zone. इसी OCTA आपके पास नहीं है, लेकिन आपको पता तो होना चाहिए उसके क्या चीजें उस पे हम देख सकते हैं। एंड सेकेंडली द कैपिलरी ड्रॉप आउट एरियाज, द डेंसिटी ऑफ द कैपिलरीज इज डिक्रीज्ड। OCTA की रिपोर्ट पे आ जाता है कि जी ये डेंसिटी इतनी है। सो आप फोवियल एवेस्कुलर जोन देखेंगे, वेस्कुलर ड्रॉप आउट एरियाज, कैपिलरी ड्रॉप आउट एरियाज देखेंगे, उससे पता चलेगा आपको इस्कीमिया कितना है। सो आई वुड सजेस्ट, ये आपकी प्रेजेंटेशन बहुत अच्छी थी, लेकिन इसको थोड़ा सा क्लिनिकल टच दिया करें, 2-3 बंदों से डिस्कस कर लिया करें। ये डिफरेंशियल डायग्नोसिस की जो लिस्ट है ना, ये हमें खुद बनानी चाहिए, शुड नॉट बी कॉपीड फ्रॉम टेक्स्ट बुक, क्योंकि अंग्रेजों की लिखी हुई किताबें हैं, वो सार्काइडोसिस और लाइम डिजीज और वो जो इंग्लैंड और अमेरिका में है वो ऊपर लिखते हैं, ट्यूबरकुलोसिस और ईल डिजीज नीचे लिखते हैं। तो वी शुड हैव ट्यूबरकुलोसिस, यूवेइटिस एंड ईल्स डिजीज एट द टॉप ऑफ द। इन्फेक्शंस हमारे मुल्क में ज्यादा है, सो पहले हम इन्फेक्शन कंसिडर कर। बाहर के मुल्कों में इन्फेक्शन ज्यादा ट्रीट हुई होती हैं, इसलिए उनके यहाँ जेनेटिक और ईडियो ऑटोइम्यून डिसऑर्डर्स वो ज्यादा है। सो आप बाहर जाएंगे तो इंटरन्यूक्लियर ऑफ्थेल्मोप्लीजिया आपसे पूछेंगे, एब्डक्टिंग निस्टैग्मस पूछेंगे, थायराइड पूछेंगे, माइस्थीनिया पूछेंगे। सो ऑटोइम्यून डिसऑर्डर्स पे वो ज्यादा जोर देंगे बाहर के एग्जाम्स में। हमारे यहाँ कॉर्नियल ओपेसिटी हो या इन्फेक्शन ऑफ द ऑर्बिट, इन्फेक्शन नंबर 1 है ब्लाइंडनेस के कॉजेज में, कॉर्नियल इन्वॉल्व। सो ऑलवेज रिमेंबर इन्फेक्शंस नंबर 1 इन आवर सेटअप। और ईल्स डिजीज, और इसको कैसे डिफरेंशिएट करेंगे? पेशेंट आ गया, वेस्कुलाइटिस है, फंडस पे हेमरेजेस हैं, पेरीवेस्कुलाइटिस है. सो व्हाट आर द डिफरेंशिएटिंग फीचर्स between Eales disease and Behcet's disease? Okay, good. Or excellent. So history examination, systemic examination, or
इसमें जो है वो posterior segment ज़्यादा heavily involved होता है, patient जो है वो tan होता है,
good, good. Eales disease में विट्राइटिस नहीं होगा, एंटी यूवेइटिस नहीं होगा, हेमरेजेस होंगे और वेस्कुलाइटिस का एलिमेंट होगा. सो और ट्यूबरकुलोसिस में क्या डिफरेंशिएटिंग पॉइंट होंगे? ये बेहशत. सो इसका प्रोनाउंसिएशन कुछ लोग बहशत करते हैं, कुछ BEH करके बहशत, जो प्रोनाउंसिएशन टर्किश है, और कुछ जो इंग्लिश है वो बेहशत कहते हैं. तो दोनों एक्सेप्टेबल है. So, how will you differentiate Behcet disease from tuberculous uveitis? दोनों एक तरह प्रेजेंट कर सकते हैं, पोस्टीरियर यूवेइटिस के साथ, और फॉर दैट मैटर सार्काइडोसिस, उसमें भी पेरीवेस्कुलाइटिस होगा, उसमें भी शीदिंग होगी, हेमरेज.
venous involvement ज़्यादा होती है, phlebitis और whereas Behcet जो है वो arteries and veins both are involved.
गुड, गुड, ठीक है. सो बेहशत डिजीज में क्लिनिकल फीचर ज्यादा इंपॉर्टेंट है. बाकी जो डिजीजेज हैं उसमें आप यू हैव लेबोरेटरी सपोर्ट, और अब जैसे साइकोडोसिस में आपके पास एस भी है, लाइसोजाइम एंजाइम भी है, कैल्शियम फॉस्फेट भी है, एक्सरे चेस्ट. और बेहशत में आप पैथोलॉजी टेस्ट है और क्लिनिकल फीचर्स हैं. So the important message is, take home message is, you should diagnose the condition and start the immunosuppression with full force. ये नहीं है कि पहले कतरे डाल के देख लें, फिर उसके बाद 2 गोलियां खा के देख लें, फिर उसके बाद जरा 4 गोलियां करके देख लें. नहीं, उतनी देर तक डैमेज हो गया, ऑप्टिक डिस्क पैलर हो गया, तो यू कांट डू एनीथिंग. ठीक है.